Hello and welcome to the ASBS International Residence Forum podcast. On today's episode, we will be talking about board exams in plastic surgery and clinical prep strategies. This topic is a big stressor usually for residents as they start to finish their residency and get ready to start a practice and be able to get their board certification, especially for being able to get accredited to hospitals and start working. So I think this would be a good episode today to kind of get some more information and get some tips out there for the residents that are getting ready to take their boards. Um, so on today's episode, we're lucky to be joined by Dr. Murphy to talk about the board exam strategies. I'll turn the mic over to Dr. Murphy to introduce himself.
Thanks. Thanks so much there, Armin. Good morning, all. I'm Bob Murphy. My current title is Enterprise Chief for uh, Network Development at Jefferson Health. My legacy is through having spent a career at Lehigh Valley Health Network in Pennsylvania. Um, um, I've in my life, in my couple decades of work, I've been a program director for or assistant director for the entirety of my career. I've had the ability to get out and about in the world to talk about education, to see how different areas and regions educate their trainees during my time as the president of the American Society of Plastic Surgeons and the president of the International Confederation of Plastic Surgeons. So it's always been an area of great interest to me. It's been an area where I've seen a lot of evolution over the last couple decades, and it's something that we owe ourselves as a profession to make sure that that we train folks in the way that prepares them best to be great physicians and great plastic surgeons, because after all, it's our ultimate duty to make sure that the patients that we care for receive the best quality care we can. So, an incredibly important topic, and I'm very honored to be the one to be able to speak to that today with you, Armin.
Awesome. Well, welcome. We'll jump right into it. So, can you talk a little bit about the board, plastic surgery board process in the U.S. and the components of it, and then if you know any differences between what we have in the U.S. and what other residents do around the world at different countries?
Sure. Well, I mean, the board process in the U.S., the board exam process in the U.S. has evolved as well as it has in the rest of the world. So, uh, but the basic format has remained the same over the last many years. The basic format being in preparation for the boards. Uh, every year during your training, there's an in-service exam which ensures that you're getting the basic knowledge about anatomy, physiology, um, technical components of the uh, of the practice of plastic surgery, to make sure you have the knowledge base to be a competent plastic surgeon. And competent is different than proficient. After this kind of preliminary stage, as you get to the latter part of your training and senior residency years, you then come to the point where there's a written board examination, which is kind of the culmination of all the information that you've had to garner over the 6 years of training, and that you've been tested on during those years of training through the in-service process. And then finally, there's an oral board examination, which in the US assumes that if you've passed the written examination, that your knowledge base is sufficient, and that in the oral boards, the focus is are you an ethical and competent plastic surgeon, in how you practice uh, the profession, because the oral boards is given after you've been out in your practice, out of training for a little while. So it's a even though the board process itself is a kind of two-phased process. When I'm talking to my residents, I talk about it as being, basically a 6 years of training and a couple of years being out. So it's not quite a decade's worth of intellectual commitment, but it is something that counts on your growth, both from a pure didactic and knowledge base, but also your maturation over the course of years as a practicing surgeon.
No, that's great. I agree with that. And kind of off of what you just mentioned, is there, do you think, one component of the board exam, whether it was the written or the oral, that you find candidates tend to underestimate and maybe not prepare well enough for, especially if we're talking about international students who are coming from outside of the US and not really familiar with the board process?
Yeah, that's a good question. Because I think that obviously being an American educated and American trained educator, I think from the one side we can see that um, the the competence that we all take for granted is, you know, the people who go into medical school are the ones who've been able to buckle down and be very high achievers during their undergraduate years. The folks in medical school to get through have to go through a very rigorous, strenuous, scientifically focused academic curriculum. Uh, and then the in-service focuses on those factual type of learnings that are important for our specialty. So we kind of take that for granted, and happily there's enough material that's out there, either in the form of direction from your program directors, from being able to resource old in-service examinations, and by able to resource the ASPS EdNet resources. So I don't think people take that part of the examination process for granted per se, because it's kind of what we've been used to from the time you were in high school to the time you finish your training. I think what people maybe underestimate a little bit is is the fact that the clinical based examination, the oral boards, is not just about knowing what nerves come through the optic foramen, or what innervates certain muscles, or what the vascular types of certain flaps are, but that there's a practice and an approach to a patient that goes into how one performs an operation and takes care of a patient. And so it's the whole milieu of what it means to be a practicing ethical and competent plastic surgeon independently, that's hard to really feel comfortable with going into the oral examination, because it's the first time you've been asked to take an examination. It's not based completely on fact, but wherein facts are assumed, competence in facts are assumed, but really wants to try to look at the individual and how the thought processes go, how they would handle stress if something were to be not quite the way they had proposed, and the like. So it's being comfortable in your approach to layered and complex thinking, as opposed to a simple question and answer approach.
No, that's great, and I think you have brought up a few good points. And one thing that I keep hearing you saying is, being an ethical and competent plastic surgeon. And me myself, I'm in the last year of my training and getting kind of starting to prepare for boards and both written and oral. And I do hear this a lot as well, especially as my mentors tell me, is one of the reasons that residents don't pass or the candidates don't pass the board exam is on ethical cases, or they did something that wasn't ethical, or the answer that was given. So can you talk a little bit more about that? How do you think candidates should prepare for these ethical or professionalism scenarios during like their case prep period to get ready for these oral boards?
Well, if you'd allow me, Armin, I'd like to kind of rephrase the question in a way because I don't think someone should prep to be ethical, right? And I'm sure you'd agree on that.
Absolutely.
I think what somebody has to prepare in is if we talk about how the American boards are given, right? So the American boards are there are some known cases, and then there are your cases. So, uh, so in the known cases, the board examiners will sit down in a room and will show you pictures and say, okay, what's your diag, and you would then have to to go through a series of thought processes and be able to impart to the examiners that one, you understand the diagnosis, two, you think this is the problem with it, three, this is the surgery that I would go through to fix that, four, this is what I do during the postoperative phase. So that's the one point. What differentiates uh, the higher level that you refer to is you also have cases that are taken from your own practice, and this is where things go a little awry sometimes. In that one, sometimes cases that are selected are cases that are complications, things that did not go right, and that's not. I think there's a defensiveness that we all have when we're taking exams in front of
Right.
mentors or in front of people who are highly placed or wrote the textbooks. Um, there's a defensiveness and a wanting to defend. Um, and really, what we're looking for as examiners when we're going down the cases of complications isn't necessarily justification. It's more to understand how you handled that, what your thought process was, and then how you proceeded to take care of the patient. One red flag would be is if someone had a couple complications and the solution to every complication was they would refer to a colleague. Um, that kind of would have an examiner say, well, you know, um, why would you do that? Of course, if it's a highly complicated reason, that would be the best thing to do. But what's your criteria? What's your threshold for wanting to hand off a patient that is your responsibility? There's good reasons. By all means, if someone's far more competent in a complicated situation, by all means, that's the best thing to do. But just what your thought process is there. The other thing, and I think that this is where you referred to the ethical, is that plastic surgery, in its most global terms, is market a market sensitivity Googling uh, terminology that applies to us, of course, as the 8,000 board certified plastic surgeons and the ASPS and the other 4,000 or 4,500 international members of ASPS, and then the other board certified in their own countries plastic surgeons globally. Um, but board certification is a reflection on a lot of things, and it's a very competitive world within our own specialty. Then add in the other specialties who participate in cosmetic or plastic surgery, And market pressures are very, very significant at times.
Right.
And what you know, and people entering practice, or and certainly as people evolve their practice, these market pressures are a source of significant concern. How you enter into a market as being someone whose skill and professionalism is taken seriously and is attractive to people seeking that type of service. So there's the want to be recognized as a board certified plastic surgeon, and the use of certain terms like board eligible, for example, in advertisements, not really endorsed by the American Board of Plastic Surgery. How you structure some of your advertisements also might call into question, um, uh, you know, how you're approaching this as a professional, who provides a high level service, or as a technician who is merely interested in generating patient throughput. Um, and then, of course, the ethics of how you not necessarily what you bill, but what billing practices are, or in addition to advertisements, billing practices, or how you do handle your complications. So those are the things where it really gives the examiner an ability to have some insight, not just what your technical competence is, but what type of person you are, and do you represent the profession and the specialty well, and do you do what is ultimately in the best interest of your patients, which is whether it's the Hippocratic Oath, the Oath of Maimonides, um, is the principle by which we enter medicine, take an oath, and then are charged with being, a very privileged small set of the population who's entitled to do very invasive and dangerous things on our fellow citizenry. So, um, the cautious, the ethical, the thoughtful approach is really what the second part of the oral examination is all about.
Well, that makes sense, and yeah, I appreciate you rephrasing the question, and kind of everything you said is very important. So I'm gonna shift our focus to board prep. So are there any strategies you've seen from the residents you've trained, or recent board certified plastic surgeons that have recently just passed the boards of tools or resources they've used? I know, for me, I've been told there are mock oral exams often offered by regional societies that I can participate in. I've heard creating a group of 3, 4 different residents and practicing together. I know there are several courses available that people can take. So I guess, have you heard one is better than the other, or any tips of how to prepare for these?
Well, the thing that I always recommend to the residents that I've trained over the years, Armin, is not to look at the boards as 2 days in your career, and kind of approach that in an all in, but as just all in as much as we're going to do, very intense studying or preparation around those 2 days. It's part in garnering the knowledge over time. So you reference a lot of very, very good resources. So I know the one that we've used to great advantage in ours um, has been the following. I mean, first, when we give our didactic lectures over the course of the 6 years, one of the things we like to do is at the end of the lectures is highlight potential by having one of the faculty moderators or one of the more senior residents moderating the session to actually select a couple questions, either from old in-service exams or from the ASPS EdNet, and at the end of the lectures, put out some of those questions so people can start thinking of what the important topics might be contained with any lecture that we have. Um, and then, of course, as anyone who's been in training for any amount of time, when you're sitting across the table doing a case with the attending, the the over the patient discussion of what you're doing, and memorializing that at the end of a case, what was you come out and you sit down with the attending, or if not the attending, you sit down by yourself and say, well, what were the two things in this case that I came away with that were different than what I thought was going to happen, um, or different than I planned, or was unique about the case. So I usually like to to take away after any interaction something that made that especially worthwhile or different from what you'd seen or heard about or prepped for before. So that's the base of that, and then of course you prep for the in services. And as you get to your senior year, when you're taking the writtens, it's what our folks do is internally, um, they do, as just as you say, they have sessions where they'll get together and they'll go through for a half an hour, or an hour, old in-service exams, and take sections of old service exams. And just the mind and muscle memory of taking exams on plastic surgery, just that seems to improve people's, um, my trainees' comfort level with the exam itself. And then also they come away with, additional knowledge base to take those exams well. Um, with regard to how to prep for the oral exam, this is one that, I think is a very important thing to do. Is just like I said at the end of a case, to take down the one or two things that made a difference. The other thing is when you're prepping for a case, you shouldn't just be prepping for, okay, I'm going to have to dissect around the hypoglossal nerve, and I'm going to use 10-0 nylon to do this microvascular anastomosis. But the other thing I like to do when I'm over a patient or after a case is, when I'm discussing with things is, okay, what if I like to play what if or whys, and I like to ask three questions on what if or three whys. What if this wasn't as you thought about it, or what if this went wrong? Because what I like to tell the folks I teach is it's not going into a case and knowing what to do when things are great. It's going into a case and being prepared for what to do if something goes wrong, so that there's no panic and you're prepped for it, and and everybody around you is prepped for it. So I think that's a helpful technique as you're doing your cases during training to say, well, if this goes wrong, if this happens, what am I going to do? And that preps you for how to think about cases going into the oral exam. That's going to be how the examiners are going to approach the questions and the cases that they present to you. And then I do think that I did find personally myself, and most of my trainees have found that one of the oral board prep courses is often helpful, um, just for that, to teach you how to organize your thoughts, how to organize your books. Not that you couldn't do it by yourself, but there's often a comfort level in knowing that there's a template, not a template, but a manner of approaching both the preparation for the exam and the preparation for how to put together your books, your case books, that many people find helpful. And again, I refer most people to the ASPS EdNet or the old board prep course that's given at I believe it's in August by
Yeah.
ASPS.
The dreaded case logs and the books. So can we talk about that for a sec? I know this is probably a much broader topic than for this podcast, but um, is there any strategies that you suggest to effectively organize them? I know, again, people dread making these. There's pictures you have to take. There is documentation that you have to put together, and I know, again, talking about how to do this is a broad topic, but just maybe a few tips of how to effectively organize it, if you have or know of any ways of doing that.
Yeah, I think that's a great question, and happily, pla- plastic surgeons and the mindset of most plastic surgeons is we are kind of OCD and we're kind of meticulous to begin with, so that's a help. But what I've seen by being helping my residents, but by being an examiner over the course of the years is the best thing to do is not to delegate. The best thing to do is to be that compulsive individual, so that so that you routinize for the time that you're out in practice, and you're the 18 months of accumulation um, of cases you're going to be going through there, that you that you routinize, that you do get pictures of everybody. You routinize the fact that it's probably best to do your dictations, particularly since you're starting out, right when you're done with the case, so that you can dictate with the a clear recall of what happened. Um, it's also one of the things that gets into the billing or ethical. There's never a billing question on what you charge. There's always a billing question if the wrong code is used or something like that. And the excuse is, well, my office manager does my billing for me, is not acceptable. So so to own the relationships and own the case preps and do the dictations right away, and even if your manager does the coding, to check the codes, um, to assure the fact that how things go out represent the way that you would have them, um, be submitted to an insurance company. Um, and then the uh, the actual format of the case is pretty prescripted by the board. So it's not how you put them together; it's how you stay abreast of fulfilling all the requirements, and then that that when you go and make the record requests, you're 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 comfortable with the fact that most of the things are going to be there, and you're not going to have to try to trace something down or something's not absent. Um, that so that you own the case from start to finish. And in some ways, electronic medical records are the bane of people's existence, but in some ways, because if they're too cursory, if they're too formatted, and they don't give you the opportunity to some color or detail around the dictation, it has its own issues. But if you build out templates in such a way that you do have the ability to be descriptive, um, and you make sure you're covering all your bases, then that can be helpful and makes things more systematized. So the more you can build your system from your first patient interaction to your discharge of your patient, so that it just becomes muscle memory and computer memory, the less pressure you'll have to make up for the fact that there may be missing components of a case that the board might be requesting, and would be important for you to have all the information at fingertips.
No, those are really good tips, and I've heard actually mostly exactly the things that you've mentioned. And the biggest thing I keep hearing is the billing part, especially like if you work at a huge hospital system and you have a team of billers that you've never met before, and they're just working behind the scenes to bill these cases. It's becomes very important to go back and make sure you review all of that, you approve them appropriately, and you know what's being billed. So Appreciate that. So as kind of we're getting towards the end, I wanted to move away from all the clinical stuff. I know we've been talking about the red board and the oral boards. Do you have any tips, or what do you think what non-clinical skills can play a significant role in helping people pass the oral boards? Anything that people can work on or kind of be on the back of their mind as they're going through this process?
Yeah, I think again, part of my academic slash institutional pedigree is analytics and quality and the like. And um, I did refer to it briefly before, but I think one of the things that makes for a good plastic surgeon is that by our very nature we are problem solvers, and and what helps, I think, our minds um, evolve and mature in that regard is, you know, again, to get through medical school and to get into, through parts of residency, we have to be very, very skilled at fact recall. But what sets I think plastic surgery apart is our creativeness, our ability to respond to problems that other people find daunting. And and if you take away from, I referred to it before as the what ifs or the whys. If you take away from the business world and operational management insights, there are quality and efficiency theoretical constructs called Six Sigma, Toyota Lean, and the like, and that's what they encourage. They encourage folks not to get trapped into the routine that I've done, you know, 1,000 carpal tunnels, but this on the 1,001st, there's this bizarre-looking tumor that's extending from the distal forearm through the carpal tunnel that's giving you the sense of the numbness and tingling, right? It's the it's the playing kind of a mind game with yourself about the in the under Toyota Lean. You're supposed to be asked yourself five whys to any problem. Under Six Sigma, it's slightly different, but the idea is to not just accept the face value of a case, not just accept normal procedure, but be prepared for the what ifs, um, or or understanding if something doesn't make sense to you, and you ask why, there could still be two other whys underneath that first cursory answer that would get you ultimately to the insight that you would need. So I think do not become do not become creatures of habit in plastic surgery. Always play a little mind game with yourself to try to be prepared for something different. Because in doing that exercise, when something is presented to you as a consultant that is different, you'll have the ingrained um, intellectual fluidity to be comfortable in that ambiguity and to be creative and to come up with different answers to problems for which there is usually one answer, but in this certain circumstance, that answer doesn't apply because the CT angiogram showed the pedicle wasn't good or something like that. So always, um, as you're evolving and maturing in your training, um, when you're developing that intellectual skill set, always visit the gray, and not just the light around the cases that you'll be dealing with. And I think that'll serve you well not only for your oral boards, but how you approach problems in life, and certainly how you practice good plastic surgery over several decades.
Amazing. Well, I want to give a special thank you to Dr. Murphy and our listeners for coming on today's show to talk about board exams in plastic surgery. As I mentioned earlier, this is a huge stressor for residents and candidates that are going through the board process. And I hope this episode gives some tips and strategies and ways that can help reduce the stress as you're going through the board process. Thanks again for joining us on the International Residents Forum podcast. Be on the lookout for the next episode if you're a resident or fellow in plastic surgery. We encourage you to join the ASPS International Residents Forum. It's a place where you can connect with peers across continents, across educational resources, and be part of a global community committed to professional growth. Thanks again for turning into the ASPS International Residents Forum podcast. Be sure to catch our next episode. See you then.